This is presented by HOD, a common disease, which is a breadwinner in a day-to-day practice, and it will definitely come into the examination also. Okay.
So it is
we
a
have
horse
benefited,
and not a zebra.
monetarily, I have benefited from the disease. Okay. So it is, the incidence is increasing in the world, right? So recently we have heard from the Delhi AQI. Okay. So abbreviation I will expansion I will ask you. Okay.
Yeah, no. Did they say?
I'll come later.
Good morning, everyone. So we, Farina, Ahil and myself, Ashita, will be presenting this case. Master Praveen, 4 years, 3 months old child, studying in LKG, residing in Nagarkoil, father driver and mother homemaker. Informant is the mother, reliable informant. Came with the chief complaints of cough for 3 days, running nose for 3 days and breathing difficulty for 1 day. The child is having wheezing from 2 years of age and is now on MDI, meter dose inhaler. Now complaints of running nose for 3 days, watery, non-foul smelling discharge, cough for 3 days which is insidious in onset, spasmodic, dry back, more at night, aggravates on exposure to dust and relieves on MDI. Breathing difficulty for 1 day. No history of associated symptoms like prolonged sneezing, headache, itching, skin lesions or conjunctivitis. No history of fever, no history of loose stools, poor weight gain and recurrent respiratory tract infections. No history of regurgitation of food and post-stressive vomiting. No history of foreign body aspiration. No history of allergy to any non-food and medication.
Okay. So now you tell me, it is a child is below 5 years. Okay, it is a preschool child. Okay. Then coming to the cough, you remind the cough. It is a dry type spasmodic cough. Okay. So what is more important than sentence? What is the diurnal variation?
More at night.
More at night and on the early morning. Okay. Aggravated by exposure to dust and relieved by MDA. What MDA?
Formatron and Wilson.
Oh, correct. And so what do you ask the history of no history of regurgitation of?
Actually, formatron should not be used below 5 years.
But I will come later, the 2023 and 24 GINA guidelines I will come later. Okay. So what is that? Weight is marked and everything. Okay. So why is important? That the regurgitation of the post-stressive vomiting. GER. Okay. So that will simulate what it is can precipitate spasmodic cough and wheeze. Okay. So that is one of the DD. Okay. So no history of foreign body aspiration. Can you tell me what is the history of cough and wheezing in the case of foreign body aspiration?
So unilateral wheeze with sudden body.
So history. Is it
History of
insidious,
sudden-
acute, or something else?
It will be sudden
Sudden, instantaneous. Okay. The child will be playing on the floor, especially child who has passed 9 to 10 months of age, very curious to probe the environment. So suddenly child will be having instantaneous cough and breathlessness. So and the child will become bluish. So what is the developmental milestones associated with this foreign body aspiration? Mature pincer grasp. Okay, that is at 10 months. Okay, very good. Okay, so no history of allergic to food or medication. Okay, next.
Past history, there is a history of exacerbation once in 5 months, 5 to 6 months with respiratory symptoms on exposure to dust since 2 years of age, which is relieved on MDI with spacer and face mask. There is history of hospitalization once in 3 years of age with severe acute asthma requiring pediatric ICU admission, which relieved on nebulization and injections. The child is now on easy to MDA, that is salmeterol and fluticasone, 1 cup to twice daily since last 1 year and takes the medication regularly. For last 6 months, there is no night and daytime symptoms.
So this child had been admitted in the hospital for severe wheezing at the age of 3 years, and at that time they have rightly started water controller in the form of ICS and Pharma, that is a salmeterol. Actually, the below 5 years you don't use what drug? Pharmaterol or that's lava. Okay, either salmeterol or pharmaterol we don't use usually. So that is a mistake they have done. Who done? I don't know. Okay, so that should not be used. So for that children, the preventive drug is ICDs, inhaled corticosteroids. Okay, so that is one. And after that admission, they have started what? Is preventive drug. Then only the child had the relief of frequent attacks of wheezing and cough. Am I correct? So your history is like that. The child is having recurrent spasmodic cough and wheezing from the age of 2 years. Okay, and they got relieved with SABA. And only after, during the past 6 months, that is 3 years of age, they got the preventive drug or controller drug. Okay, so during the last 6 months, they don't have any nighttime or daytime symptoms. So is it well controlled or poorly controlled or partially controlled?
Well controlled, sir.
Well controlled. Right. Next.
Antenatal history is, this is a second order child, is a non-consanguineous marriage. Age of conception of the first child is 25 years and the age of conception of the second child is 30
So next
years.
we can go. Next.
Natal history, that is preterm delivery at 34 weeks. The indication is the previous LSCS card witness. The birth weight of the child was 2 kg and there is no delay in passing meconium.
Okay. Is there any significance?
It's a cystic fibrosis.
What will happen? Cystic fibrosis.
There will be delay in passing meconium.
Cystic fibrosis causes wheezing.
Yes, sir. There will be recurrent respiratory infection, steatorrhea, and wheezing.
And failure to cry. Okay, right. Very good. Next.
Postnatal history, the baby was admitted to ICU for preterm care for
Is
15
this
days.
baby AGA or SGA? AGA or SGA?
That's why it's only 2 kg.
34 weeker.
What is in the growth?
Usually we say no 34 weeker. What is the importance of 34 weeks? They can suck and swallow and can be given to the mother. And usually they will be above 1.8 kg. Okay. They will be around 1.8. So this baby seems to be 80.
Had breathing difficulty, was on CPAP for 4 days, followed by supplemental oxygen by hood. Weaned off oxygen by the end of first week. Feeding was done by express breast milk initially by the OG tube, then gradually shifted to direct breastfeeding.
So this baby is 34 weeks gestation, and this baby had been in the ICU for respiratory care, CPAP, and will any complication, respiratory complication in the baby. The assisted ventilation can facilitate this. Your symptoms in this age, the recurrent symptoms. Can any condition do this with this?
Bronchopulmonary dysplasia.
So what are the causes of bronchopulmonary dysplasia? Preterm baby is one.
Preterm baby, prolonged ventilation.
Prolonged ventilation, assisted ventilation, then exposure to what? What drug? Oxygen is also a drug. So that can cause bronchopulmonary dysplasia. This will cause recurrent respiratory infection and wheezing, failure to thrive, recurrent hospital admissions, and recurrent inhalation of ICS. And these all these similar history can present. Okay, but the baby is growing well. Okay, so weight everything is normal. Okay, next.
Nutrition history, exclusively breastfed till 6 months of age. Complementary feeding started at 6 months with formula feed and ragi.
So any exposure to any type of milk can cause asthma, exposure to
Below the age of 1 year.
unmodified cause. So if the breast milk is inadequate, what will you do? You try to counsel, and if it is inadequate, you will get modified cause milk in the form of formula feed. But that doesn't promote, but the breastfeeding is best. But cow's milk should not be offered to the baby before 1 year of age. Okay. But even in the asthmatic child, cow's milk can be given after 1 year 3 months of age. Okay. Next, so if possible, that is egg protein can be avoided in atopic family. Am I correct, madam? Egg white.
Now the thought is that early introduction will lead to oral tolerance.
Tolerance. So this controversy or not?
It is controversial.
Controversy. Okay, so your calorie protein. Okay, right. Next slide. Is it adequate or not?
So the required calorie is 1283 kilocalories, but the intake is 725 kilocalories. So there is a deficiency of 558 kilocalories. And the protein required is 15.9 grams, but the intake is 26 grams. So there is 10.1 grams excess.
I would like to caution you here. You will be caught by some examiners.
You will be caught if you say, when there is an energy deficiency of 700, if you say protein is excess, are you making a sensible statement? No. If the child needs energy, what will the child do? Use the protein for energy. And 1 gram of protein will give how much energy? 4 kilocalories. So 10 gram of protein will give 40 calories. This 10 gram excess is not going to do any good for the child, but will be wasted instead of a samosa. You could have given the child now 40 calories. So you must say that protein seems to be adequate in numbers, but there is a huge energy gap. And then comment on whether it is a complete protein or an incomplete protein. And mainly it is of vegetarian source. You must not say that protein is excess, especially when there is energy. You got the point. Many students and postgraduates tell like that, and they are caught by certain examiners.
Immunization history, all vaccines given till date according to the National Immunization Schedule. BCG is present. The last vaccine given was vitamin A, MR dose, second dose, and BPT first booster dose, and OPV first booster dose. In the nearby PHC, influenza vaccine 2 doses were given.
So given, so 4-year-old child influenza vaccine 2 doses given. So what is the primary vaccination schedule of a child below 6 years for influenza vaccine? From 6 months onwards, you can give
From 6 months
influenza
on,
vaccine.
2 doses should be given in the interval of 4 weeks, sir.
Okay, very good. Okay,
So,
up to 6 years. Okay. Now they are telling even at up to 8 years, the latest guidelines say up to 8 years you have to give 2 doses. Okay. So after 8 years you can give single dose if it is primary vaccine. So otherwise, what is the advantage of why you are giving very particular about this influenza vaccine in asthma? Why?
So this is given for the asthmatic patients and immunocompromised to prevent the
Asthmatic children are not immunocompromised.
and immunocompromised patient.
No. Why this asthmatic, why this easing patient, if it is not immunocompromised, cystic fibrosis or something, why you are giving?
To prevent precipitation of asthma.
So even without you are the child get asthma, multi-trigger disease, okay, even without you are a child get asthma, why you are preventing? Because any common sense, because influenza is a severe condition which will cause hospital admission in a case of asthmatic child. So that you want to prevent. So that's why you are giving influenza vaccine in an asthmatic child. Okay. Next. So development is normal. Okay.
Yes, sir.
Next. Okay.
Family history, no history of bronchial asthma in parents, no history of contact with tuberculosis patient, and siblings, the elder sibling, age 9 years, has intermittent episodes of respiratory tract infection with WHEEZE requiring nebulization.
So how it is important? Family history
Is
of
it
asthma.
infection or is it also asthma?
It's an infection.
How do you know?
So all these are first degree relatives. Okay, mother, father, and your sibling. So first degree relative, no history of asthma in the parent. Okay. So how it is important? Do you know any?
Body like
Very good. Asthma predictive index. What is the major criteria? What is the minor criteria? Okay, especially preschool children who get this recurrent spasmodic cough, recurrent wheezing, we may not be in a position to judge whether to start ICS as a controller drug or not. Oh, but this asthma API, asthma predictive index, will be useful in the form of any child having three episodes of wheezing in a child, okay, and with the one major criteria among the two, that is one major criteria is physician diagnosed asthma in either parent. So what is second? Physician diagnosed atopic dermatitis in the child. Okay, what are the minor criteria?
minor criteria, we have a physician diagnosed allergic rhinitis in child, and eosinophilia more than 4% or absolute eosinophilic count more than 400 cells, and history of cough and wheezing without any upper respiratory tract infection.
So more than 3 episodes in a year with the one major criteria or 2 minor criteria is there, means the preschool child with these symptoms, with these criteria is positive, means you can boldly prevent this further episodes of attack with the ICS, especially below 5 to 6 years. Because when you give only SABA alone, so what is the disadvantage? According to JINA guideline 2024 is this child, the future control of asthma, the ICU admissions with asthma will be very severe. Okay, that's why. So that's why this criteria is still standing for test. Okay, so it is useful. Okay, next. So tuberculosis. Why tuberculosis and your wheezing is related? Why?
So it's an asthma memory, sir. It's a differential diagnosis for tuberculosis.
So tuberculosis can cause respiratory infection with the prolonged wheezing, not this acute episodes, but the prolonged wheezing. Okay, insidious onset with the failure to thrive. Okay, difficult to control asthma, and in that cases, X-ray will be more useful to diagnose than asthma cases. Okay, so that's what tuberculosis and asthma. That's wheezing is related. Okay, next.
The sibling needs re-evaluation.
So usually after 5 years,
We also should be
respiratory infection is not needed in a case of asthma for precipitating wheeze. Okay. So even without URI or LRI, that can wheezing can occur. Okay. Next.
Socioeconomic status, the family belongs to the lower middle class according to the modified Kupusami scheme. They live in a pakka house, no overcrowding at home. Food is being cooked on gas stove, no history of pets at home, no history of mosquito repellent usage or presence of construction site or damp environment nearby.
Why this pakka house is important to prevent asthma?
Dust like exposure.
Okay, dust. Not only dust. Fire, what is it? Mold. Mold is also a trigger for asthma. Okay. And regarding this, why this gas stove? Do you think gas stove doesn't facilitate asthma? No, sir.
firewood. We are not using firewood.
So last month, this personal experience. So I had a very good discussion in my family with my home minister. Okay, she was so her resource person, the latest scientific the updates are by the recent advance of my 2 daughters. Okay, elder daughter and younger daughter. They are very active in the social media. So IT engineers. Okay, so my home minister was telling. So the US recent advances, they say the US, I am a infrequent visa. So in the US they are saying even cooking gas, this usual cooking gas, natural gas will facilitate asthma. So why can't we switch over to electrical appliances? So I already know that. I immediately told that with my income I cannot afford electrical appliances. And I cannot meet up to, so every month 20,000 rupees for electrical supply. Okay, that I did. So no, even though I can afford, I refuse to wait. because the US scientists and the European scientists will tell you next year or 2 years so even cooking itself with electrical appliances will be harmful and better you order online Swiggy or Zomato. So that is I am afraid of that. So that's why I repeat it. Okay. So this is my personal experience. Okay. So think globally but act locally. So that is very important. Okay. So that's why important to be feasible. Okay. So cooking gas, there is true, there is cooking gas with the nitrous oxide that is produces the precipitate asthma, they are saying. Okay. So that the 2023 Science magazine has done. Next.
General examination, the child is alert and awake, no pallor, no interest, cyanosis, clubbing, lymphadenopathy and period edema.
So child is alert, awake, okay, not drowsy at all. Is it irritable or not?
No sir.
Usually asthma children will be very irritable. So asthma, okay. So elderly, anybody having asthma, they will be irritable, especially women. Members of the family, if you get a mother-in-law, you will be finished. Right? Next. Why this clubbing and lymphadenopathy?
So clubbing is to rule out separate lung diseases like empyema, bronchiectasis, lung abscess and cardiac causes like clubbing, infective
Even
endocarditis.
65 also classes clubbing. 4-year-old child. Lymphadenopathy?
For TB, sir, rule out TB.
Tuberculosis. Okay. So tropical disease. So and why cyanosis?
So when there is severe respiratory distress, the patient might become cyanosis.
Saturation less than 85. That child will not be awake. Child will be drowsy. Okay. The ICU. Next.
Head-to-toe examination, no allergic shyness, allergic salute, any more than pulse, dry skin lesions, no Cushing-like features, no chest
Then
pain.
what is then more than like inferior margin? Okay, there will be usually there will be 2 transverse lines. If it is more than 2, that is 3 means that there is any margin line. And the second is what is this? Allergic salute. What is this allergic salute?
So due to constant rubbing of nose, there will be transverse lesions on the nose.
Do you know the one Tamil Nadu chief minister, my favorite chief minister?
MTR.
Asthmatic. His allergic rhinitis. MTR used to do like this. So MTR will be doing like this. Okay. So actually because we have this allergic rhinitis and it is a visceral also. Okay, he is considered this MDA kind of okay. So this what is this? What is the line this called? There will be transverse line. Okay, the nasolabial power there will be transverse line because of allergic salute. And any signs of allergic rhinitis inside the nose?
So there will be inferior tubular hypertrophy, that will be because of this listening.
Okay, and listening.
Where do you look for the shyness?
So around the eyes, nocturnal visits were hypopigmentation. Okay.
Vitals, partial.
No pushing and features. Why?
Because the patient is on, child is on steroid therapies.
Okay, see these quacks, they are giving prednisolone or dexamethasone, usually dexamethasone in the powder form. Even I had the these people, along with this Siddha people are giving this dexamethasone in the powder form for chronic control asthma. So such children, they come to you, so they will be having pushing and features. Okay, so that's why it is important. Yes.
Vitals, pulse rate is 114 per minute, regular rhythm, normal volume and no radio delay or radio pulmonary delay. Respiratory rate is 42 per minute, abdominal thoracic.
So with this spasmodic cough and breathlessness, child is having SpO2 in room temperature or with oxygen. Room temperature it is 95. Is it normal?
Yes, sir.
So child is compensating. Okay.
BP 100/70, SpO2 95%, CFT less than 2 seconds, temperature 98.4 degrees Fahrenheit, which is 8
ICS, medium or high dose of inhaled corticosteroids, can they develop short stature?
Yes, sir.
9 months to 1 year, minimum 9 months to 1 year, they can develop mild short stature, mild growth is right delay can be there. Right. So usually asthmatic children are not undernourished. Usually they won't be undernourished. Right. Next.
Systemic examination, respiratory system inspection, upper airways appear to be normal, trachea seems to be in midline, there is no use of accessory muscles of respiration, chest is bilaterally symmetrical, no visible scars and sinuses, no chest deformities.
Usually the child is having frequent wheezer without our control medication. What is the shape of the chest in asthma shape? Barrel shape. It is anteroposterior diameter equal to transverse diameter. Okay, asthmatic child. It is uncontrolled asthma. Okay. Next.
Palpation, palpation, trachea is in midline, chest expansion equal on both sides, no palpable sounds, apex beat, left foot intercostal space in midclavicular line. On percussion, it's hyperresonant in all areas. Auscultation, vesicular breath sounds heard, air entry is equal on both sides but this decreased. There is bilateral expiratory wheeze present with prolonged expiration and high-pitched musical polyphonic bronchi is diffusely heard.
So here the child is having vesicular breath sounds. Okay. And if it is very good that child you have had this respiratory wheeze you have had. Asthma is a respiratory wheeze. Okay. High pitched polyphonic bronchi you have had. So I complete that. But this is, suppose the child is not having wheezing. The child is having breathlessness. Without wheezing, can you diagnose asthma by auscultation?
There's a chance that it's a
Spasmodic cough, feeling tightness, can you diagnose asthma even without wheezing? Suppose you can hear wheezing. So without this, can you diagnose?
So there can be two conditions, cough variant asthma, other is silent chest because of severe respiratory distress.
So then, your child is awake.
So, cough variant asthma.
I am not telling dangerous asthma. There is silence that I am telling. I am not telling where there won't be inspiration at all. There is inspiration is there. The sacred breath sounds is there. But child is having asthma.
Cough variant.
Huh? So if you auscultate carefully, if you are experienced, you can say that inspiration will be there. Expiration will be usually prolonged. That's why here it is expiration is prolonged expiration. So even without wheezing, you can diagnose asthma. Normally inspiration prolonged, expiration prolonged. Normally inspiration is okay. So here the respiration will be very much prolonged. So there can be if the child having breathlessness, you can diagnose asthma. Okay. Next. So polyphonic
Cardiovascular system, SMS to heard, no murmur or added sounds heard. Periabdomen examination, soft non-tender, no liver or splenic enlargement, nervous system, no focal neurological deficiency.
If a child is young baby, 6 months or 7 months old baby is having these with the tachypnea, with the hyperoscopy on the belly, and what will be the diagnosis?
So normally less than 2 years, liver is
If
palpable.
it is not Nagari, it is palpable.
Liver is palpable, sir.
So 6 or 7 months old baby.
So because of hyper.
Both the liver and the spleen are obviously palpable. Child with the breathlessness and tachypnea.
Because of hyperinflation, the liver is pushed down, sir. So it's
So
palpable.
all the diseases are not only asthma, there are other conditions also. Disease that is called acute bronchiolitis. There will be push down liver and push down spleen. Okay.
Summary: a 4-year-old male child who is a wheezer for 2 years, since 2 years. Second born out of non-consanguineous marriage, came to history of running nose, cough and breathing difficulty with past history of severe asthma exacerbation, which required PICU admission and was relieved on nebulization and injections. He is on salmeterol and fluticasone therapy. On examination, tachycardia and tachypnea present, bilateral expiratory wheeze present with prolonged expiration, bilateral high-pitched musical polyphonic bronchi diffusely heard.
Diagnosis.
Diagnosis in case of mild acute exacerbation of bronchial asthma.
So in case of bronchial asthma, previous episodes of admissions was present and they have started prevented blood And why you are saying it's mild acute example? Why?
So because the child is alert and most importantly his saturation, oxygen saturation is 95, which is, and also the sensorium
Child
is
is able to talk in sentences.
Yes.
Okay.
So there is no.
So this, will you do any investigations to confirm your diagnosis or straight away you treat?
Mostly it is a clinical diagnosis. If you have to do any
Asthma is a clinical diagnosis. Okay. Next.
so to rule out any other causes, we do chest X-ray.
So indications for chest X-ray in case of this.
TB, we can rule out TB, acute bronchiolitis.
So child having prolonged fever, cough more than 2 weeks continuously. Okay, wheezing also continuously, serious onset, okay, and failure to thrive. Family history of tuberculosis in the mother or neighborhood or the family, intra-family. So then you have to take X-ray test, okay, with no family history of asthma, first episode. Then you have to do X-ray test. Any other indication for X-ray test? You told that. And if there is clubbing, or people edema, will you take X-ray test or not?
Cystic fibrosis too.
That is this all this condition, what to take X-ray test. And lymphadenopathy, cervical lymphadenopathy, significant cervical lymphadenopathy also, you have to do X-ray test. This is first episode. Okay. Any other test you want to do before starting treatment? Will you start treatment or not?
We start treatment.
What treatment?
So we give
So mild acute exacerbation, what treatment?
short-acting beta agonist in MDA 4 to 10 pounds. Usually we give
So usually preschool children, GINA guidelines 2023 says it's for not 4 to 10. Okay, it is 2 to 4. That is enough. Okay, so before 5 years. Okay. Next. How many times you will give? First time you are giving. How will you then give that? Any you directly you put the MDA or will you give any?
So we give MDA with spacer and the face mask.
Very good. So MDA with face mask and spacer. Okay, right. So will you give the 2 or 4 puffs at a time?
No sir, every 20 minutes.
20 minutes.
Interval.
20 minutes you will be giving this for 2 to 4 puffs. But every puff is single time.
We'll wait for 30 seconds.
So you want to share this, okay, this MDA, okay, 5 to 7 times, and then each puff, the child, you observe the child through the spacer, the child is taking that 7 to 10 times inspiration, okay, then you, okay, so 20 minutes, 20 seconds you so 30 seconds to 1 hour, then 1 minute you give the time, then you put second puff, okay. So similarly, 2 to 4 puffs can be finished, okay. At a time, don't give these 4 puffs, okay. So that is very important, okay. So that can be asked in the examination, and your spacer and MDA will be kept in the medication, okay. Your ASCII station also, they will be Viva and the ASCII, they will be kept, okay. Right. Next, what will you do? After 20 minutes, what will you do? If there is improvement and if there is no improvement, what will you do?
After 1 hour, if there is improvement, we will see.
So, after 20 minutes, you are observing the work the child is there. First puff you are given. First the medication you are given. After 20 minutes, if there is no improvement, what will you do?
Hypertrophic bromide.
No. Will you repeat or not?
Yes, we will repeat.
You want to repeat the same course after 20 minutes if there is no improvement, and you wait. If there is improvement in the work, child will be there. This is what we are doing. Okay. So we will be doing this too in an evaluation, but MDA is enough. So the child can be managed in the home also. Okay. So the same thing child can asthma action plan. You can write the written asthma action plan that can be given to the home also. You want to advise. Okay. So that time also you can repeat. If there is second time it is no improvement. So 3 times within 1 hour, every 20 minutes, 3 times you can repeat. So after 1 hour, you have to watch. Okay, if there is improvement or not. Okay, if there is improvement, you can send the child home without any other drug and giving counseling and repeat the same like that in the home. Okay, and continue the what?
Long-term management.
Controller drug. That is ICS, you know. It's a preschool child. Okay, the ICS dose is 100 microgram budesonide. So the child is having budesonide or something fluticasone.
Fluticasone and salmeterol.
So we are known angels. So known angel here as a pediatrician or madam or anybody. Okay, so we are very experienced with the budesonide than fluticasone. Okay, and budesonide actually we use 100 microgram BD. So before 5 years you use 100 microgram BD.
Presentation you must say whether the child is on low dose ICS, moderate dose. What is the strength of the cancer also you must say.
So above 100 microgram in a preschool child, you have to base your diagnosis or you have to investigate. Okay, right. So you advise that you continue that 100 microgram BD. Okay. Then if after 1 hour if there is no improvement, what will you do?
Then we will give hydrocortisone.
No. Child is awake, saturation 95.
The child is in the emergency now. What will you do?
We will check the oxygen saturation.
You can start prednisolone. 1 to 2 milligram per kilogram per day. Okay, and in the meantime, you can give ipratropium. Okay, so you can give 250 microgram. This side you can give 250 microgram ipratropium. Okay, if there is no improvement, means you can admit the child. Okay, admit the child to the ICU and give
Oxygen.
hydrocortisone. What the dose?
Hydrocortisone.
What the dose? 10 milligram per kilogram. Stack dose followed by 5 milligram per kilogram 6th hour. So that is the dose. Okay. Even with hydrocortisone, there is no improvement. Very good. IV magnesium sulfate. What is the dose? Latest GINA guideline. Previously used 30 milligram per kilogram. Now the 2024 GINA guideline say is 50 milligram per kilogram. Okay. So you have to give diluted with normal saline and you have to give infused for 30 minutes. And here you are giving IV means again sulfate. What precaution you want to take?
We have to monitor the vitals.
What vital?
Respiratory rate.
So similar to it is bronchodilator. Similarly, it will cause dilatation of the systemic arteries. So you want to rule out the hypotension. Okay. So better this take this drug in the lying posture. Okay. Child should not be erect. Okay. So I have used this ICU for many years. I have not seen a severe hypotension with magnesium sulfate. Okay. So that is safer precaution. Okay. Right. Next time. Suppose child is running with what is the life-threatening asthma?
Life-threatening asthma, there will be silent chest. Please will not be here. The child will be
Child will be
restless and
child will be
drowsy.
drowsy. Child will not speak. Okay. Child will be having cyanosis and chest will be silent. So what will how you treat a case of this life-threatening asthma?
We will admit the patient in ICU.
Immediately the casualty, you want to give nebulization. The casualty itself, we want to give 10 milligram per kilogram of IV hydrocortisone or 2 milligram per kilogram of methylprednisolone and immediately shift the child to ICU. Okay, right. Thank you. So now theory part, can I continue, madam?
Yes.
When will you decide this MDI is not going to work? Because in acute exacerbation we said give 4 puffs back to back, 1 minute apart, and 20 minutes later again you can give the MDI. So when will you decide that MDI is not going to be useful, this child has to be given nebulization? To receive MDI, the child should be able to sit upright and breathe. Suppose that the child is very drowsy and the breathing is irregular, and child cannot be made to sit up even. It is lying down. Then we need the machine. Otherwise, if a child can sit up and is breathing normally, we can give the MDI. Okay.
What is the adverse effect of salbutamol? Then tachycardia. A child is coming with exacerbation. What will be the heart rate? There will be tachycardia. Will you give salbutamol? No. Why? Why there is tachycardia? Because of the flare up of asthma. Then why you are not giving salbutamol? Huh? That case you have to give salbutamol, and again you count the pulse rate will come down because your breathlessness has come down, or the stress to the child because of the hypoxia, that will come down, the heart rate will come down. So that is not a contraindication for giving salbutamol. You have to monitor the heart rate.
And I think the canister is programmed also not to release one after other. It has to have a latent period. Then only it will release the next fluids. You can push, but it doesn't mean that it will release the medicine.
So very good presentation. So we have a reverse it and therefore okay. So to know the frequency and the incidence of bronchial asthma and wheezing in a child, okay. So preschool wheezing, that is below 5 to 6 years, is 50% of the children will have at least one wheezing in there before 6 years of age. So before 6 years, recurrent wheezing will be 30%. Is it a small number or a high number? 30% of the children will be having recurrent wheezing. Okay, so this recurrent wheezing may evolve into asthma after 5 to 6 years of age. So that you have to keep in mind. Okay, so that's the incidence. And polyphonic wheeze. So polyphonic wheeze and monophonic wheeze. So polyphonic wheeze, what does it mean is typical of bronchial asthma. That is, ஒரே baby, ஒரே child, ஒரே stress வைக்கும்போது same area you will hear multiple areas are also you will say different tones of high pitched bronchi, different tones like a Ilayaraja music. 50 to 60 instruments எல்லாம் ஒரே டைம்ல போட்டா எப்படி rhythm வருமோ அதே மாதிரி monophonic wheeze, the polyphonic wheeze will be like that. Okay, simultaneously. The darling first time you get a part of the part first time, okay, the time 1970s something, okay. So monophonic wheeze means it is a classical of foreign body. So foreign body expression. Here not only expiratory wheeze, there will be inspiratory. So usually bronchial asthma we hear that expiratory wheeze. Here inspiratory wheeze also can be heard. So there is very classical of this monophonic wheeze. இது எப்படின்னா ஜெயசுதாஸ் வந்து first தமிழ் சினிமால okay introduced by this MS விஸ்வநாதன். first பாட்டு ஜெயசுதாஸ் கொடுத்தது அப்படின்னா ஒரு பிச்சைக்காரன் பாடுறது, பிச்சைக்காரன் என்ன வச்சிருப்பான், ஒரு ஃபிடில் மாதிரி ஒன்று வச்சிருப்பான், ஒரே இன்ஸ்ட்ருமெண்ட். ஜெயசுதாஸ் அப்படி யங் ஏஜ், மலையாளத்துல வந்து யூ வாண்ட் டு ஷைன் தமிழ், நீயும் பொம்மை நானும் பொம்மை, அந்த பாட்டை கேட்டாலே தூக்கம் வரும். அந்த ஃபிடில வாசிச்சு ஜெயசுதாஸ் டிசைடட் என்ன தமிழ்ல எதுவும் வரவிடாம பண்றதுக்கு இந்த வேலையை பண்ணியாச்சு, நான் இனி கேரளாவுக்கு போக வேண்டியது தானே அப்படின்னு டிசைட் பண்ணும்போது ஹி ஸ்டேட். பாவம், ஒரு நேரம் 2 நேரம் சாப்பாடு இங்கே ஹோட்டல்லாம் சாப்பிட்டு நெக்ஸ்ட் வந்து ஒரு நெக்ஸ்ட் ஃபிலிமில் அதே MS விஸ்வநாதன் கேட்டே வெரி காதலிக்க நேரத்தில் என்ற படத்தில் அந்த பாட்டில் தான் அது வந்து ஃபேமஸ் ஆகிருக்கு தமிழ். ஓகே, and etiology. here there is watering. Okay, every viral infection, usually viral infection can cause precipitate wheezing associated with watering. Okay, and it is atypical organism like chlamydia and mycoplasma. So why this atypical organism is much talked recently during the past 3 or 4 days in Delhi, AQI, that is a Delhi pollution. Walking pneumonia has become very common in children, school-going children, compared to any other type because of atypical organism. So whether this because of pollution that stimulate this recurrent offending this small airways and medium-sized airways and that precipitate walking pneumonia in children. Okay, so that become very common. So that's why they have closed the schools in Delhi. Okay, they are taking online class. Okay. So this another thing is usually young infants with the wheezing, we invariably take echocardiogram, especially 6 months old baby, echocardiogram and X-ray test to rule out undetectable. Okay, with left to right shunt. Okay, any DSD were to rule out. Okay, so that's why you are taking pulmonary edema. They can present as wheeze in a young child. Okay, and typical symptoms are these. Spasmodic cough. Sometimes the cough may be a only symptom. That is cough variant asthma, especially very classical of young children. Like cough variant asthma, not only young children, school-going children also. We have diagnosed many cases of spasmodic asthma, spasmodic cough without any classical signs of hospitalized wheeze and night time or daytime exercise-induced cough. I have put so many children with many pediatricians has failed. I have put a trial ICS even 10 years ago. Okay, for the next 2 weeks, they are family is very grateful to me because they are reduced the symptoms of cough. Because I learned theory. Okay, at that time. Okay, so the theory actually knowing theory is very useful to for treatment and applying in the practice. Okay, so these are the typical symptoms of asthma. Another one is interval symptoms. In between episodes of acute exacerbation or moderate exacerbation of asthma, in between that, child will be having nighttime cough, frequent throat clearing, and everything. So that is called the interval symptoms. This interval symptoms is very typical of atopic condition. Okay, multi-trigger is in a preschool child or asthma. Okay, that is one. And limitation of exercise and activity. So that's the classical of asthma. School activity is more. So that comes into step 3 or step 4. Okay. And it triggers you to asthma. Triggers they are already presented. Smoke and everything, mold and everything. Pets, furry pets and laughing, even crying and laughing can precipitate wheezing and breathlessness. And family history of atopic family history you are to ask. And very important is documented airflow limitation. Documented airflow limitation may be by the doctor by auscultating wheezing or by PEF1. Peak respiratory flow rate less than 80% are expected for that age using this height and age chart. So PEF or mammogram is available, easy to apply. So you are doing a research on that. Okay, what wheeze is doing. Okay, and another thing is documented reversibility. Okay, so once a child is having wheezing and you are applying the giving, you are doubtful whether child is having asthma or not, breathlessness is due to spasmodic cough. To give that first you measure the PEFR, then you SABA. Okay, SABA, and again you measure the PEFR. If there is 15%, 10 to 15% improvement of that, that is a documented reversibility of cough or spasmodic cough or breathlessness. That means it is a confirmatory of asthma. No further there is a evaluation is needed. You can straight away treat. So pulses paradox. Some examiner you are answering well, some examiner may ask what is pulses paradox. Especially Vijay Kumar sir married. He will ask what is pulses paradox. So theoretically, pulsus paradoxus means systolic degrees of 10 millimeter of mercury. I don't know. Okay. So Sarasari ada vandangana, Surat vandangana kya? Sharnavas Maria. And how do you know the systolic degrees of 10 millimeter? So during inspiration, a child is having breathlessness or asthma or wheezing. So severe wheezing, especially severe asthma will produce that pulsus paradoxus. Okay. So if you palpate the pulse, so there will be drop on the pulse during inspiration. That doesn't.
Actually, pulsus paradoxus.
So it is for exam question purpose only.
Paradox is that it is not the pulse. It is the BP fall we are measuring during inspiration. Normally it is 10, more than 20 is significant. That is what. We will include it in pulse, but it is actually the drop in the blood pressure.
So already so I wanted to complete that. Sir, my severe wasting, asthmatic child will not be undernourished. Wasting is so cystic fibrosis and the bronchitis will cause wasting. Silent chest feature, severe asthma, the inspiration also will be affected. Okay, so there won't be the air movement should be there for eliciting this wheeze or bronchitis. Movement, air movement, chest will be silent. There is a dangerous DA condition. So the diaphragm asthma. So hepatomegaly, push down liver is a severe asthma or bronchiolitis or this wheezing with bronchiolitis, push down liver and spleen will be there. But liver will be actually enlarged in case of cystic fibrosis. Okay. All these atypical features better to take X-ray chest, CT, HRCT. And this is two words you want to remember. This is preschool child. So that is episodic viral wheezing. So any respiratory infection will precipitate, especially during the rainy season. Recurrent URI will not. Next day there will be child will be having spasmodic cough, bronchi with or without bronchi will be there. That is the but only URI will precipitate wheezing. That is called episodic viral wheezing in a preschool child. Very common. OPL varvadella idha. So you remember that. Another one is multi-trigger wheeze. Multi-trigger wheeze means not only respiratory infection, any trigger, any chocolate or dust mite, or change in climate, current chillness, AC cold water, histamine release. Okay, so all these cause trigger exercise and crying and laughing will be that is called multi-trigger wheeze, not only URI. So usually this multi-trigger wheeze in future many of the children will become asthmatic. So this statement is not from me. This is from the GINA 2023 guideline. Okay. So here there will be interval symptoms. What are the interval symptoms? Apart from acute exacerbation, there will be epipathology immunity response. Epipathology throat clearing பண்ணிட்டே இருப்பாங்க. எப்ப பார்த்தாலும் அவங்களுக்கு ஒரு அனீசியா இருப்பாங்க. Okay. So night tomorrow, night tomorrow, 4 days interval symptoms இருக்குது. And so this is one important point. Okay. So any child having cough, wheezing, breathlessness lasting less than 10 days. Okay, less than 10 days after each URI, 2 to 3 episodes per year, no symptoms in between. That is called episodic viral. Okay, that's called. So few have asthma. Okay, but symptoms and cough and breathlessness, spasmodic cough, everything lasting more than 10 days after URI, more than 3 episodes per year. So you apply your ATA, asthma predictive index, family history, so yeah, these patients some may have in between the episodes, some will be having interval symptoms, some may have asthma. The other history, definitely these children will be having asthma. So better to put this last column on the rose column. So better to put that children into what preschool child. I say yes. So you should not treatable asthma is a treatable condition. And the my condition is whether you put this child on as ICS, don't refer this child to a pulmonologist. Pulmonologist can go to a case where there is it. Okay, how the capability is there a case. So you want to treat yourself. Okay, so to increase the pediatric OP and the reputation of our pediatric department. So your OP number is controlled. Yeah, so you want to do that. So yeah, don't refer only by pulmonologist or other funding. Spirometry, patient will be lost. Yeah. So I want to see how many cases do you know? How many cases I have put the ICS? Can you tell? But the imam, 3 cases are put during the last 1 year. Many cases I have put is last in the ICS. Even without the X-ray, I have put this ICS. Okay. Again coming to asthma predictive study. So that's major criteria and minor criteria. Okay. Right. So diagnosis means recurrent attacks of this spasmodic cough indicates asthma. Recurrent attacks. Bronchodilator response is there. Right, this clinically confirms asthma. Nothing else is needed. The child is normal. Okay. Weight is normal. Okay. Alternative diagnosis of asthma. When there is airway reversibility, okay, and the wheezing is not there, non-responder, okay, and the red flag signs, clutching and failure to drive, and hepatomegaly, and fetal edema. So, other than that, you better cover to even so, because of the addition. Sir, you can come to this. So different diagnosis already. So there is weak respiratory flow rate. That is the inexpensive equipment. Whether she is doing or not, I have never seen her with a weak less than 80%. Okay, even less than 80%. That is the weakest one. It's easy to measure. Okay, any child with above 5 years in Sonalo, I practically use above 8 years. So the coordination of fast forceful respiration should be there. So forceful respiration, say theoretically, peak respiratory flow meter can be given above 5 years, but practically for our children with coordination of breathing, everything, then it takes minimum 7 to 8 years to use that. Okay. And this already I told you. So X-ray chest is not needed unless there are other red flags there or to use it. That is a bilateral asthma cases may be normal. Okay, now there will be bilateral hyperventilation. Okay, it will be there. And bronchiolitis, there will be bilateral hyperventilation. The scattered areas of infiltration because of atelectasis. Okay. So this is the recent advances means expression of nitrous oxide. Okay, that is the one confirmatory method. In eosinophil, that means eosinophilic inflammatory condition that is occurring in asthma, there will be FeNO will be increased. Sir, my example on the asthma. Okay, I won't ask. So all these deep test and the specific IgE is difficult to control asthma. These are pulmonary. So yeah, okay. So they will be for their domain. So yeah, this okay. So otherwise, what industry want to do is EPC and this absolute eosinophil count, eosinophilia more than 4%, and pulse oximetry, IC, and the reliever and control is very important. Okay. To treat bronchospasm, that is called reliever. Control is to prevent this further recurrent episodes of wheezing. Okay. In a persistent case of wheeze, more than episode that multi-trigger wheeze and asthma cases. So reliever, SABA is very important. Short-acting beta agonist, that is very important. And GINA 2023 guideline, even 2022, they have included what? Formoterol with ICS. So as a reliever for children above 5 to 6 years. Especially older children, adults, they have included formoterol with ICS. The reason I will tell you. Okay. And controller, my experience with the butadiene is better than other drug. Okay, so beclomethasone same as butadiene and the fluticasone is very effective. Okay. Second reliever is if there is no improvement after 20 minutes interval, 3 doses, and no improvement, you can start the oral prednisone 20 mg, 2 mg per kilogram, and also give ipratropium bromide. Okay, so that is 250 microgram for less than 10 kg, and more than 10 kg you can give 500 microgram. Okay, and controller, long-acting beta agonist. So here, salmeterol better you don't use because it is the duration of action is 12 hours. It is actually more than 12 hours. So if you give twice, dose stacking may occur and will cause complications, drug complications. So practically, please don't use salmeterol. Okay. So for practical purposes, you use formoterol as a preventer drug, controller drug, both as preventer and reliever. Okay. Formoterol and leukotriene agonist. So 2023 they included in the step 2 and step 3 management. 2024 also they are about, I think 2025 they will start recommending leukotriene agonist as a controller drug. Why? Very good. So chances of post-market surveillance done so many years of telling that it is the cause of depression and suicidal tendency. So better avoid. So 2025. So known devil is to the unknown angel. So the pair is okay. I am not using. So July 2024 July they are categorically use FDA as preventer. So ban US FDA ban 2024 July.
Getting marketed like left and right in India.
But they were US FDA they have won. So banned I don't know. But I am not using after July 2024. I am not using. So this is a spacer with the mask with the FDA. Okay. So this is very useful for children less than 5 years and above 5 years. Spacer alone is enough. And above 5 years and they are telling above 5 years spacer and above 8 years spacer is not needed. I am using this spacer even in children with 8 years, 9 years, 10 years because the coordination will be better with the spacer and your mouth ulcers will be lesser. And that is what is asthma. Your theory paper you may be asked about the counseling in asthma. So then you have this asthma action plan at home. So asthma action plan you have a EPA 40-page note. What is the frequency of asthma? Daytime, night time, every week. You can assess the initial steps you need to control asthma. Okay, from the daytime symptoms, nighttime symptoms, what medication is needed to relieve that symptom. So asthma action plan use. So asthma counseling will be very useful, and the parents also will be very cooperative because something different you are doing. Okay. Severe exacerbation already mentioned. And then coming to under 5 years, so you know that above 5 years, any adult physician can treat. So under 5 years, so management at home is that is salbutamol, inhaler. So now, GINA guideline 2024 clearly says better not to use oral salbutamol. So think globally. Act locally we cannot avoid prescribing salbutamol. Then what is that? Syrup. So still we have to use. But the patient's parents are very cooperative. They understand. Okay, the side effects. Then we use salbutamol as an inhaler alone. So Western countries they are not using salbutamol as a syrup in children because the side effects are more. So the inhaler salbutamol is very useful. The SSP 2024 clearly says so no further salbutamol oral dose. So preschool children, what is the FDA? 2 to 4 puffs. Okay, every 20 minutes. I already told you. Okay, then how will you manage? Okay. So under 5 DC. So what drug to put for as a controller drug, that is ICS alone. So preferably budesonide or dexamethasone 100 microgram BD. Okay. So if you are the multi-trigger disease, you suspect 3 episodes, interval symptoms also present, means you give this ICS 100 microgram BD for 6 weeks. 6 weeks like there is improvement, means this child is going to become asthmatic after 5 years. So you continue that. Okay. If there is no improvement, send to pulmonologist. So this one I have already told you. So stepwise management of asthma. What is the step? Initial management, the child has been put 6 months back with the ICS and this smartug. Okay, how they assess? This is the assessment. So first, there is initially the child had infrequent symptoms less than 2 episodes per month, means this step 1. Okay, and symptoms more than 2 episodes per month, but not daily. Step 2. Symptoms almost daily, and nighttime symptoms more than 1 week. So early morning I will be tired and the school of the refuse. Okay, and step 4 means almost daily daytime symptoms and low lung function and nighttime symptoms. Step 5, uncontrolled symptoms. Better to refer step 5 to pulmonologist. Okay, and 6 to 11-year-old children. Okay, see step 1 and step 2. Okay, they are putting this low dose ICS. Okay, and whenever there is acute exacerbation, they are putting SABA. Okay, so reliever drug water now they have to give SABA whenever is needed, along with ICS. So now the latest current recommendation is not only use SABA for relief, you use ICS also relief. So that is called what? MARC, maintenance and relief of blood. Okay, and step 4 and step 5 high dose and glucose agonist is recommended, but we are not using 2024. They are recommending 2025 guideline. They will remove. I hope they will remove FTRE. Okay. Patient education and counseling. This is very important. Okay, asthma action plan and what are the home environment, what to avoid. Okay, and the damp environment should be avoided and cockroaches should be prevented. There is a vacuum cleaner, there is a bed sheet and vacuum clean. Okay, choosing and okay, well controlled. So each side is well controlled because daytime symptoms and nighttime symptoms are vastly reduced. So in a case of well controlled asthma, so your child is a peaceful child, well controlled with the ICS. Okay, so partially controlled means partially these symptoms will be there. Poorly controlled means many of the symptoms will be there. Okay, thank you.